Today we're tackling the second stage of labor. So, that crucial moment when you're actually pushing the baby out.
Yeah, exactly.
And we're lucky enough to have this amazing comprehensive review article. It pulls together a ton of research studies, even some recent guidelines.
Yeah, it's really a shortcut for us to get to the meat of what we know.
So our goal is to really break down the evidence, move beyond just tradition, give you the information you need to understand what really are the best approaches.
Yeah.
So let's start with something kind of basic. What position a woman uses during the labor? Yeah, you might think this is pretty straightforward, but it actually has a really interesting history.
Yeah.
Traditionally, across cultures, we saw a lot of upright positions for birth, standing, squatting, sitting.
Yeah.
But in modern Western medicine, it's way more common for women to give birth lying on their backs or in a semi-sitting position.
Yeah, like reclining or even in that lithotomy position where the legs are up.
Like, as many as 68% of women are giving birth in that supine position.
Yeah, it's really become the default.
So why this shift? It's not just random.
No, not at all. There are a lot of factors that contributed to that change. Way back, the invention of forceps in the 18th century,
Right.
that kind of started to shift things. And then with the rise of physician-attended births. And, those early forceps were big and they're kind of clunky. And being in that lithotomy position, lying down, probably made it easier for physicians to use them.
Yeah, makes sense. Right.
Yeah. And then, so as we move forward in time, childbirth starts increasingly happening in hospitals in the early 20th century. And then we add in things like twilight sleep, which was that heavy sedation they would use,
Right.
and the widespread use of forceps at that time. All those things really kind of reinforce this idea that giving birth lying down was just the way to do it.
So it was this confluence of events that really solidified that practice.
Exactly.
But what's interesting now is to look back and ask, what does the actual research say about different positions for birth?
Yeah, right.
And, this review looks at several studies, right? It starts with one from Australia. It's a retrospective analysis.
Yeah.
And they found that the lateral position, meaning lying on your side, had the highest percentage of intact perineums.
Right.
So no tearing at all. It was about 66.6%.
Wow.
But then squatting, on the other hand, was associated with the highest rate of, any kind of lacerations at 53.2%.
So it seems like there might be a link between squatting and a higher risk of tearing, at least compared to side lying.
Yeah, it's pretty interesting, right? And then they dive into a Cochrane review. Now, for our listeners who, maybe aren't familiar, a Cochrane review is like the gold standard.
Yeah.
They look at all the, highest quality evidence out there and synthesize it to answer a specific question.
Right. Really rigorous.
Right. So this one looked at studies that didn't involve women with epidurals.
Yeah, so focusing on unmedicated births.
Right, and they found that, unfortunately, a lot of the research in this area was of really poor quality.
Yeah, the methodology just wasn't very strong in many of the studies, and there was a lot of inconsistency. Like, different studies were comparing different positions, so it makes it hard to draw really clear conclusions.
Right. It's, when the studies are all over the place, it's hard to say definitively, this is better than that.
Yeah, exactly.
Right. But then there's this meta-analysis.
Yeah.
And now a meta-analysis is also really cool.
Right.
Because it's not just looking at one study. It's taking the results from many studies and, combining them all to try to get a stronger signal.
A bigger picture kind of thing.
Right, exactly.
Yeah.
So this meta-analysis compared upright or lateral positions to supine or lithotomy.
Okay, so non-lying down versus lying down, essentially.
Yeah, exactly. And here's where it gets really fascinating. Okay?
Okay.
They found that non-supine positions, so not lying on your back, were associated with fewer assisted births, so, needing forceps or a vacuum.
Less intervention.
Right, fewer episiotomies.
Which is a good thing.
Right, and even fewer fetal heart rate abnormalities.
Right, so less stress on the baby.
Right, but there's always a but.
Right, there's got to be some trade-offs here.
Yeah, there was some potential downsides as well.
Yeah.
So they did note a higher rate of second-degree lacerations, meaning tears, in the non-supine group.
Interesting.
And a higher estimated blood loss over 500 cc's.
So slightly higher risk of some complications.
Right. But they did say that there was a trend, although not statistically significant,
Okay.
towards a shorter second stage for women who were upright.
That makes sense.
Right. Gravity's your friend.
Yeah.
Right. But, again, not a statistically significant finding.
So something to keep in mind, but not necessarily a deal breaker either way.
Right. But I think this highlights the importance of those trade-offs, right? Because on one hand,
Yeah.
we see these benefits, fewer interventions,
Yeah.
things like assisted birth and episiotomy. But then on the other hand,
Oh.
we see this potential for, a slightly higher risk of certain types of tears and maybe a little more blood loss.
Right. And it's important to remember these are just trends based on looking at a lot of women. It doesn't mean that everyone who chooses an upright position will experience those things.
Right, absolutely. And it doesn't take into account individual factors like the baby size or the, shape of the woman's pelvis, right?
Exactly.
Lots of things come into play. Now, the review also looked at a Cochrane review specifically for women with epidurals.
Okay, because we know that can change things.
Right, and that one didn't find any statistically significant differences in outcomes.
Between positions.
Yeah.
Okay, interesting. So maybe having an epidural sort of evens things out in terms of those position-related risks and benefits.
Potentially. And they also noted that there were a lot of methodological inconsistencies in the studies they looked at.
Right, so again, it makes it difficult to draw really strong conclusions.
Right. And the review actually highlights some limitations with this whole area of research.
Yeah, what kind of things?
Well, it's hard to blind people, right? I mean, the doctors, the nurses, even the woman herself, they know what position she's in.
Right, you can't really hide that.
Right. And women don't always stay in one position. They might move around. And estimating blood loss is notoriously subjective.
Yeah, it can be really hard to measure accurately.
Right. And most of the studies didn't really differentiate between the position used for pushing versus the position for the actual birth itself.
Okay, so they kind of lumped those two things together.
Yeah, which could definitely affect the results.
Yeah, for sure.
So when it comes to making recommendations about maternal position, what can we actually say?
Right, what's the takeaway?
The review is pretty clear on one thing: avoid the supine position.
So lying flat on your back.
Right, generally not recommended.
Okay.
They say that being upright or on your side offers some benefits.
Yeah, that aligns with what we saw in some of the research.
Right, and then they suggest that squatting or sitting might be especially helpful if the second stage is taking a long time.
Right, so if things are kind of dragging on.
Right, or if there's a medical reason why the baby needs to be born more quickly.
Okay, so in certain situations, those positions might be particularly beneficial.
Exactly. And then they also suggest that side lying or hands and knees might be helpful for reducing the risk of tearing.
Okay.
And then there's even this idea that maybe being upright is good for pushing,
Yeah,
but then switching to side lying or hands and knees for the actual birth.
interesting. So kind of like a two-step approach.
Right. So the overall message here seems to be that there's not a one-size-fits-all answer, right?
Right.
It's about talking to your provider,
Yeah,
understanding the benefits of those non-supine positions,
right.
and then choosing what seems best for your individual situation.
Yeah, it really highlights the importance of individualized care and shared decision-making between the woman and her healthcare provider.
Right, exactly. Okay, so let's move on to another interesting topic: delayed pushing. You might hear this called laboring down or passive descent.
Yeah, I've heard those terms too. It can be a little confusing.
Right. So can you break it down for us? Like, what exactly is delayed pushing?
Sure. So delayed push-in basically means that a woman is fully dilated, which is that magical 10 centimeters we hear about,
Right.
but she doesn't feel a strong urge to push yet.
Okay.
So instead of immediately starting to bear down, she's encouraged to just rest
Okay.
and kind of let the baby descend on its own
Okay.
until that natural urge to push kicks in.
Okay.
And the idea here is that this can give the baby more time to move down and rotate through the birth canal, potentially making things easier for both mom and baby.
Got it.
And it can help conserve the mother's energy so she's not pushing for as long,
Okay.
and hopefully increase those chances of having a spontaneous vaginal birth.
So it's like working with your body, not against it.
Exactly. And interestingly, the review mentions that most midwives actually report this as their typical practice for women who have epidurals.
That's interesting. Okay, so let's talk about the evidence for delayed pushing, especially for women with epidurals.
Yeah, that seems to be where it's most commonly used.
Right. So what does the research say?
The research on delayed pushing with epidurals is actually pretty compelling. We've got multiple randomized controlled trials, which again are considered the gold standard for research.
Right.
And these trials randomly assign women to either push immediately or delay pushing.
Okay.
And then we've got several meta-analyses that combine those results from multiple studies to get an even bigger picture.
Right.
And most of these studies have focused on women having their first baby.
Okay.
And there's a common finding. When pushing is delayed, the overall second stage of labor tends to be longer,
Okay.
but the actual time spent actively pushing is significantly less.
So it's like you said, spreading the work out.
Right.
Okay. What about the outcomes for mom and baby? That's really what matters.
Right, exactly. And the meta-analyses showed that delayed pushing led to a roughly 10% increase in spontaneous vaginal births.
Oh, wow. That's significant.
Yeah, it is.
So 10% more women are able to avoid things like forceps, vacuums,
Eh,
cesarean.
exactly. And some studies found other potential benefits too, like higher rates of unassisted vaginal births. So not only did they avoid those interventions, but they didn't even need any help from a midwife or doctor to get the baby out.
Wow, that's pretty amazing.
Yeah.
So any downsides?
Well, there was one interesting finding. This large study, the PEOPLE study, which the review highlights, they did find a small increase in maternal fever in the delayed pushing group,
Okay.
but no other significant differences in complications for either the mother or the baby.
Okay.
And it's worth noting that the PEOPLE study also suggested that delayed pushing was most beneficial for reducing those really difficult births,
Okay.
where the baby's in a less ideal position, like facing forward or sideways.
All right.
Or if the baby's head is still high in the pelvis.
Got it.
So for those situations, delaying pushing might be even more beneficial.
Interesting. So it seems like if you have an epidural, waiting for that urge to push could be a good thing.
Yeah, it seems like it might be a reasonable approach without necessarily increasing those major risks.
Right. Okay. What about for women who don't have epidurals? Is there any evidence for delayed pushing in that situation?
Unfortunately, there isn't a lot of research on this for women who aren't using epidurals.
Okay.
The review only found one small study, and it wasn't a randomized controlled trial.
Okay.
But it did suggest that delayed pushing for them women might lead to higher rates of spontaneous vaginal birth,
Okay.
a shorter overall second stage,
Okay.
and a shorter pushing time, all without an increase in complications.
Okay.
But because it was such a small study and women weren't randomly assigned to those groups, we need more research to really confirm this.
Right. It's like one study isn't enough to really draw conclusions.
Exactly. We need more data.
Okay, so now let's talk about the practical question, right?
Okay.
How long do you actually delay pushing? Is there like a magic number?
Yeah, that's a good question. And unfortunately, the research hasn't really compared different time limits for delayed pushing directly.
Okay.
The studies that have been done have used different cutoffs.
Okay.
So some have waited 1 to 2 hours.
Okay.
Others waited until the woman felt a strong urge to push.
Okay.
Some waited until the baby's head was visible.
Okay.
And of course, if there was a medical reason to speed things up, then they wouldn't delay at all.
Right.
So there's no clear consensus in the research yet.
So what about professional guidelines? Do they have any recommendation?
Yeah, there are guidelines, but they vary.
Okay.
For example, in the US and Canada, the guidelines often recommend waiting up to 1 to 2 hours.
Okay.
And that depends on whether it's a first baby and whether an epidural is being used.
Okay.
The Royal College of Midwives in the UK, they advise just waiting for the urge to push with no specific time limit.
Okay.
And then the International Federation of Gynecology and Obstetrics, they suggest a little bit longer, up to 4 hours for first-time moms with an epidural,
Wow. Okay.
and up to 1 hour for moms who've given birth before and don't have an epidural.
Okay.
But, this is as long as the baby's heart rate is looking good and there's no urge to push.
Right. So everyone's got a slightly different take on it.
Exactly.
So what's the bottom line from this review? What's the take-home message about delayed pushing?
They basically conclude that it's generally reasonable to delay pushing for up to 2 hours after becoming fully dilated, especially if you have an epidural.
Okay.
As long as you don't feel a strong urge to push or the baby's head isn't really low.
Right.
But they also caution that if there's no progress or you still don't feel that urge to push after that 1 to 2 hour delay,
Yeah.
it's probably a good idea to start pushing then.
Okay.
Because there are potential risks with a really long second stage.
Right. Like what?
Well, things like infection
Okay.
or more severe tearing.
Got it.
And of course, if there's a need for a quick birth, then immediate pushing is still the way to go.
Right. So, it's a balancing act.
Right?
Right. Letting things progress naturally, but also being mindful of those risks.
Exactly. Weighing those benefits and risks.
Okay. So now let's talk about the actual act of pushing. We've all heard, those classic instructions. Take a deep breath, hold it, push.
Yeah, they kind of directed pushing. It's like a cultural phenomenon.
Right. So directed pushing versus spontaneous pushing. What does the evidence say?
Well, that directed pushing, where you're told to take a deep breath, hold it, and push hard, often using what's called the Valsalva maneuver.
Right.
It's really common, but the evidence to support it is actually pretty weak.
Really? Interesting.
Yeah.
Okay.
On the other hand, we have spontaneous pushing, and that's just allowing the woman to push when she feels the urge
Okay.
without any specific instructions.
So it's just kind of going with your body's cues.
Exactly.
Okay.
And interestingly, women who aren't using pain medication often start with those gentle, shorter pushes that gradually get stronger as labor goes on.
So it's like your body's telling you what to do.
Right, it knows what it's doing.
Right. So what do surveys of healthcare providers tell us about how they actually guide women to push?
Surveys of midwives show that most of them do allow pushing to begin when the woman feels the urge, both for women with and without epidurals.
Okay.
And they generally support spontaneous pushing for women not using epidurals,
Okay.
but only about a third of them do the same for women with epidurals.
Okay.
And a surprising percentage actually direct the pushing even for women who aren't medicated.
So it seems like maybe practice hasn't quite caught up with the evidence in some cases.
Yeah, it seems that way.
Okay, so let's dive into that research. What does it say about directed pushing compared to spontaneous pushing?
Well, the research really doesn't support routine directed pushing.
Okay.
There was one randomized controlled trial of first-time moms. They weren't using any pain meds.
Okay.
And they found that coached pushing actually led to a slightly shorter second stage of labor,
Okay.
but it didn't really make a difference in how many women had a prolonged second stage or in other outcomes for the mother and baby.
Okay.
And a subgroup of women in that study who were coached to push,
Yeah.
they actually had some negative effects on their bladder capacity.
Oh, wow.
Yeah, and increased signs of pelvic floor weakening after they gave birth.
So even though it might have shortened the pushing phase a little bit,
Yeah.
potentially some downsides.
Right, exactly. And then another randomized controlled trial in Turkey, also with women not using epidurals.
Okay.
They found that directed pushing was associated with a longer second stage.
Oh, interesting. So the opposite.
Yeah, the opposite of what you might expect, a longer time spent actively pushing, and the women just weren't as happy with their birth experience.
So even if it might shorten things a bit, it doesn't sound like it's worth it if it leads to other negative outcomes.
Right.
Right.
Exactly. And then there's a systematic review, and you know what those are.
Right.
They looked at all the research, and they concluded that directed Valsalva pushing might shorten the second stage a little,
Okay.
but it could have some negative effects on bladder function
Okay.
without any real differences in other important outcomes.
Okay.
And another review even suggested it might increase the risk of tearing.
Oh, wow.
Yeah.
And what about for the baby?
They didn't find any difference in outcomes for the baby, but, gotta be honest, that review included some older studies that weren't very high quality.
Right. So maybe not the most reliable evidence.
Right.
Okay. So it sounds like the overall message is moving away from routinely telling women how and when to push.
Exactly.
Right.
The review makes a strong point that directing pushing should be considered an intervention.
Okay.
And like any intervention, it should only be used when the potential benefits clearly outweigh the risks.
Right.
And since there's not much evidence of benefit and some potential for harm, routine directed Valsalva pushing should be avoided.
Okay.
But they do say that in situations where the baby needs to be born more quickly and the woman isn't spontaneously pushing,
Yeah.
some guidance might be helpful. So
Really?
like some gentle encouragement to push, but not that prolonged breath holding.
Right. Okay, that makes sense. Let's shift gears a bit and talk about a specific fetal position, occiput posterior, or OP.
Yeah,
Can you just quickly explain what that means?
sure. So OP means the back of the baby's head is facing the mother's back. So basically the baby's looking up
Okay.
or toward the mother's front. And this can make the second stage more challenging.
Okay.
The baby's head might not fit through the pelvis as easily, and that often leads to a longer second stage.
Right.
And a higher risk of needing an assisted birth, like forceps or vacuum.
Right. Or even a cesarean.
Exactly. So accurately diagnosing this position is super important.
Okay. And how do they do that?
Well, traditionally, they do a vaginal exam or try to feel the baby through the mother's abdomen.
Right.
But the review highlights a surprising finding. Using abdominal ultrasound, even by someone who's not an expert,
Okay.
is actually more accurate at figuring out the baby's position.
Interesting. So it's even better than a vaginal exam?
Yeah, which is really interesting, right?
Okay, so let's say the baby is in that OP position. Do they usually turn on their own?
Yeah, that's the good news. Most babies who are OP earlier in labor will actually rotate to that more favorable position,
Okay.
opert anterior or OA,
Okay.
by the time of birth.
Okay.
And we're talking about 80% of those babies will rotate on their own.
So there's a good chance the body will just like naturally correct it.
Right. The body's pretty amazing, right?
Yeah. But then the review also points out that women with epidurals are more likely to have their babies in the OP position closer to birth.
Okay, so that's something to consider when you're thinking about pain relief options.
Right. Okay, so let's say the baby is OP and it persists into the second stage. what do you do?
Well, remember that people study we talked about?
Yeah.
The one about delayed pushing?
Yeah.
They also looked at au pair babies, and they found that delaying pushing might actually increase the chances of a spontaneous vaginal birth.
Okay, so waiting could be helpful.
Yeah, potentially. And then there's manual rotation.
Okay, what's that?
That's where the doctor or midwife actually tries to turn the baby's head from OP to OA.
Okay,
And that's been shown to reduce cesareans and vacuum-assisted births.
so it can be a really effective intervention.
Yeah, it can. Now, people have suggested that certain positions or movements might encourage the baby to rotate,
Oh, okay.
but the review says those haven't been proven effective in randomized controlled trials.
Okay.
So the jury's still out on those. The review does recommend checking out the work of Penna Simkin.
Okay,
She's got a lot of great info on managing OP positions.
okay.
So the main takeaway here is probably don't start pushing right away if the baby's OP. And manual rotation can be really effective.
Got it. Okay, let's move on to a topic that I think a lot of people are curious about. How long the second stage actually lasts.
Yeah.
Because it feels like there's this unspoken pressure, like it should take this long or that long.
Yeah, like there's some kind of magic number.
Right, exactly. But what does the review say?
The review really emphasizes that there's no one-size-fits-all answer when it comes to the length of the second stage. It can vary a lot.
Okay,
It depends on whether it's a first baby,
okay,
whether the woman's had an epidural,
right,
even how often cervical exams are being done,
okay,
and how quickly providers think about intervening.
right. It's almost like there's a cultural element to it as well.
Yeah, definitely. And it's interesting, they point out that both the first and second stages of labor have actually been getting longer on average in recent decades.
Really, why is that?
Well, they think it might be because more women are using epidurals these days.
Okay,
And there have been some changes in the overall health and characteristics of women who are giving birth.
got it.
So things are shifting.
Right. And speaking of guidelines, what about ACOG? What do they say about when the second stage is considered prolonged?
So ACOG recommends considering the second stage prolonged if a woman having her first baby has been in this stage for 3 hours, if she's had regional anesthesia, like an epidural,
Okay,
or 2 hours if she hasn't.
okay,
For women who've given birth before, those timeframes are a bit shorter. If hours with regional anesthesia or 1 hour without.
okay.
But it's important to remember that these are just guidelines.
Right.
Doesn't mean that you automatically need an intervention if you hit those time limits.
Right, so they're not set in stone.
Exactly. They're just something to consider.
Okay, what are some factors that make a longer second stage more likely?
The review mentions a few things. Having a longer first stage of labor,
Okay,
being a first-time mom,
right.
having an epidural,
Okay,
higher BMI, so that's body mass index.
okay,
If the baby is bigger than average.
okay,
If the mom is older, like 35 or older.
okay,
And as we talked about, if the baby is in that occiput posterior or OP position.
right,
And it's worth repeating that epidural use is really consistently linked to a longer second stage,
right,
a higher chance of it being considered prolonged,
right.
and needing an assisted vaginal birth.
Got it. So what are the risks? What happens if the second stage goes on for longer?
The review is pretty clear that a longer second stage is linked to a higher chance of needing forceps or a vacuum to help deliver the baby,
Okay,
or even a cesarean.
right,
And they point out that your chances of having a spontaneous vaginal birth go down with each additional hour you spend in the second stage after you're fully dilated.
so time is a factor.
Yeah, it can be.
Okay,
And studies have suggested that a prolonged second stage, or pushing for more than 3 or 4 hours, can increase the risk of complications for the mother.
like what?
Well, things like chorioamnionitis.